So, hello and a very warm welcome from my side to all the participants here in the room, as well to us, to our colleagues joining us online to this session, Home Care and Support. My name is Stefanie Becker. I'm a psychologist and gerontologist by training, and I'm the director of Alzheimer Switzerland, and I also have the great honor and pleasure to be a member of the board of Alzheimer Europe. I'm particularly happy to chair this session because, as you all for sure know, living at home as long as possible is one of the biggest wishes of people with dementia and their carers, and actually for us all, I guess. But people with dementia, to do so, if they want to do so, they are facing many different obstacles, and they need support. And the support comes not only from it's not only on one level. There are so many different levels. It needs a whole environment of support. It needs activities, it needs competencies, it needs awareness to do so. And so anything we can do make staying at home for people with dementia possible is really very close to my heart, and I'm looking forward to hear and to learn from our speakers in the session today. But before we start, just a short reminder, as you've already heard several times before at this conference, this is a hybrid session, so I'd like to remind you that you can input your questions, hand in on the conference app. This means the participants here in the room as well as those online. I'll try to include as many as possible after each discussion. So, not after each discussion, after each talk into the discussion. So unfortunately I have to start with a sad information. Our first speaker, Julie Vaillant, she couldn't make it today, but as people engaging for dementia are very positive people, we look to the positive side of that, so we had a little bit more time for discussion if necessary. So okay, then I think we can start with our first speaker, which is the second, or who's the second in the program. It's Kate Brennan. She's from the National Dementia Office in Ireland. Kate worked for 13 years with the Alzheimer Society of Ireland as a regional manager, developing dementia-specific care and daycare services. Last year, she started work with the Irish National Dementia Office, and one of her main areas of work is on education and training. Kate will let us know more about the Dementia Care and Support Program, which is in a pilot phase at the moment in Ireland. And she informed me that she unfortunately also has to run to catch her plane right after her talk. So maybe if I'd stop talking now and let her talk, we have a little bit more of time for the discussion. So Kate, the floor is yours. Thank you.
Thank you. So good morning, everybody, and thank you very much for inviting me here to speak. As Stefanie said, our main focus today in the National Dementia Office at the moment is on the Dementia Care and Support Home Care Education Programme. And it's a programme for healthcare support assistants who work in the Health Service Executive in Ireland. So, just to give you a couple of steps back, in the National Dementia Strategy published in 2014 in Ireland, it states specifically that education and training is instrumental to the delivery and management of effective health and social care services. And in recommendation 3 in particular, it says that all health and social care staff should be dementia aware, that those delivering care should receive dementia appropriate training, which is appropriate to their role, and to provide understanding of the needs of people with dementia and carers. So, just to give you a bit of context in terms of the Irish situation, the majority of the 64,000 people diagnosed with dementia, they live at home in their own communities, and that's their wish. They want to maintain living well in their own homes and communities for as long as possible. The numbers in Ireland in terms of dementia are expected to increase to about 150,000 by 2045. So you all know, obviously, dementia is a neurodegenerative illness, but in the Irish context, 37% of all home care is provided to people with dementia. And that amounts to about €800 million cost to the HSE, the Health Service Executive, annually. And in Ireland, I suppose, we need to realign the care with the support in terms of the wishes of the people. And we all know, everybody knows, that people with dementia want to be in their homes with their families and in their communities and to live well with dementia for as long as possible. So to that end, we developed the Dementia Care and Support Home Care Education Programme. And just to say that the aim of this programme is to develop skilled, self-aware and reflective healthcare support assistants who are equipped to care for people with dementia with humanity, empathy and dignity, so that they may live well for longer in their homes and communities. So that's the essence of the programme and really what we're trying to capture with the programme. It's designed by us in the National Dementia Office, the Health Service Executive and Dublin City University were academic partners on that. And we've consulted with people with dementia, their family carers and healthcare staff to see what they wanted from this programme, what were the best outcomes, what they wanted to achieve from this programme. So there was quite an intensive consultation process. And last year we were successful in securing a Quality and Qualification Ireland, so a QQI Level 5 accreditation for this programme. And Irish Times Training are our partners who deliver the actual training to our learners. So there's 6 modules to this programme. So you can just see yourselves there. Module 1, how we understand dementia and why it matters. Self-awareness, care and boundaries. Understanding emotion and communication. Roles and relationships. Everyday dilemmas and a well-being approach. And learners throughout the 6 modules use a reflective journal, and they're supported by their mentor, and I'll chat about that in a minute, who they meet every week, and that can be either in person, it can be via Zoom. They meet their mentor every week throughout the duration of that programme. And the role of the mentor, it's that, I suppose, this aspect of the programme that's a little bit different. So we provide kind of like an 8-hour training programme for the mentor. So that's usually delivered over 2 mornings. And the mentors, to become a mentor, must have at least 2 years' experience of supporting people with dementia, or be in a supervisory capacity in home care provision, or have completed the facilitator training programme, or have a clinical nursing background. So they're the requirements that we've put in place to become a mentor. So the mentors will engage with the learners and act as a listening ear while the learner progresses through the modules, and they support them in both personal and professional development. And they share best practice models with the learners, discuss different scenarios that may have come up in home care and look at best practice models and how to support the person with dementia and the family carer. And the mentor's role is really to create a space where the learner can explore ideas related to their development on this course. The targets that we've tried to set on completion of the course, the participants will be able to explain the implication of different ways of understanding dementia and apply a person-centred approach to care. Demonstrate the ability to apply self-awareness, self-care strategies and boundaries in care relationships. Demonstrate a range of communication skills that support caring for the person with dementia. Look at care conditions necessary for establishing and maintaining care relationships, and taking account of the challenges and changes to family relationships where there is dementia. We want them to be able to discuss and apply ethical approaches to everyday dilemmas and apply a strengths and well-being approach to working with a person with dementia. So that's what we hope that the learners will come out with at the end of this programme. So the current situation in Ireland, as Stefanie said, the programme is in a pilot phase at the moment, and we currently are providing that pilot phase in Area 1, 4 and 5 that you can see on the map. So it's across 3 community health organisations. And that really, obviously any pilot programme, it's just to help us look at issues, iron out issues, what's working well, what's not working well. So I think we're kind of at the end stage of that pilot phase now. So 8 cohorts of learners have completed the training to date, and there's another 4 planned for the end of the year. And we hope to achieve and reach 250 learners by the end of this year. So far to date, I have to say the responses to this training from both learners, from people with dementia and family carers has been absolutely really, really positive, very supportive of the programme. At the moment, we're looking at doing an independent evaluation of this programme, so we're just going to put that out to tender at the moment. But hopefully it's a process evaluation just to look at how things have gone and what's worked well and ways to improve. So we hope to have that kind of, I suppose, in the first quarter of next year, we hope to have that evaluation completed. So just to give you an idea and just bring it more to home, these were course participants in Donegal in the north of Ireland. So one quote that really struck me, and I thought it kind of summed up this course quite well. So as a healthcare assistant, the Dementia Care and Support course challenged my thinking on the lived experience of dementia for my clients. Before the course, I just saw the diagnosis and failed to see the person behind. Now, after completing the course, I actively seek the person first through meaningful engagement, empathy, and connection. So I thought that was quite a positive reinforcement of the course. And others have said that they found the communication and ethics sections very interesting and beneficial. Understanding how to deliver the best care to my clients is an important part of giving person-centred care. Fantastic course. I have learned so much from this. I've immediately put my learning into practice and love the course. It will help me do my work better, and I know how to communicate with the person with dementia that I have the pleasure to engage with. So, as I said, feedback has been really, really positive. There's been a lot of work, I suppose, put in by different departments and different levels to the course. And we do hope that once the evaluation is complete, that there will be funding there to roll this programme out on a national level to our health support assistants across Ireland. So thank you.
Thank you very much, Kate. I think you have to hurry. I don't have any question here online. Maybe one question here in the room before. Should you have to run? Is there any? Yeah, here, over there, and over there. If you like.
Oh, yeah. Thank you. Maud Graaf of the Netherlands. I was interested in mentors. How many times do they see the learners? And yeah, hi. The mentors, how many times do they see the learners? And what model do they use to get this change in attitude done,
Okay.
what you presented?
Sure. The mentors would meet them every week, so once a week throughout this course.
Yeah.
And I suppose we select the mentors based on their experience and obviously the fact that they, are experts in the field of dementia care. Yeah. So the meeting can be done via Zoom, face-to-face, generally via Zoom since COVID. But I suppose they look at the best practice models and really reinforce that whole person-centred care and well-being approach. So I suppose there's different scenarios. Maybe the home care assistant will, give examples of scenarios that they may have faced in the home. Yeah. And you look at, okay, well, this is what I did, but maybe next time that scenario comes up, what's the better way to deal with that situation? So they talk things through, and it's a learning experience.
Yeah,
yeah.
But that's also what I think that is a good way to do. So it was more my question: do they reflect on only the behavior of the learner, or also on what the learner sees?
Yes.
That changes in the client with dementia.
Yeah, exactly. So then, the next time the learner, after their discussion, is able to go back into the home, maybe the same scenario will come up again, and they will deal with in a better
Okay.
dementia-centred way.
Yeah. Very interesting. Thank you very much.
I have one question here from on the panel. This is a wonderful training, Kate. Is there a plan for the trainee to connect back in the month after the training and link with each other? This is Susan Dooley from Dublin asking.
To link with other people?
To link with each other.
Well, the learners would be working in the same area. So they all come from the same area, so they would know each other. And the answer is no, they haven't kind of connected or come together yet after the training, but maybe that is something that we need to think about again. Yeah, so that's a good point, to come together maybe sometime after the training and just explore how things are going. So that's a really good point, yeah.
Thank you.
Thanks.
There was one more, but I don't know, I really don't want to...
That was one
question. Okay. Perfect. So yes. Okay. So thank you very much, Kate.
Thank you very much.
And have a safe trip back home. So a very warm welcome to our second speaker, it is Flora-Marie Hegerath. Flora-Marie, she is a research associate at the University of Bochum in Germany. She's doing her research at the Institute of General Practice and Family Medicine, and she's also engaged in Interdem, if I saw that correctly. She will talk about, unfortunately, very frequent situation where people during a hospital stay will be diagnosed with dementia, and she will let us know how to shape, especially the transition back home for these persons best possible in future, I hope. Thank you.
Yeah, thank you very much for the introduction. As being said, the presentation I'm giving to you will focus on the role of primary care physicians in supporting people who will get their diagnosis during an acute hospital stay. And the research is funded by the German Alzheimer Association. To the background, so a lot of older people with cognitive impairment, they usually live at home. And there they can compensate a lot of their deficits with the help of their relatives, for example. So dementia diagnosis is often delayed, even though a lot of older people do have general practitioners. And in some cases, an initial diagnosis is being made during an acute hospital stay. And as the German healthcare system is strictly divided into different sectors, it is really challenging for those involved to have a good transition from inpatient to outpatient care. And therefore, we wanted to assess in the study conducted the existing barriers and facilitating factors in the care of those patients who get their diagnosis in hospital, especially in general practice. Regarding the methods, we did qualitative semi-structured interviews. We wanted to interview general practitioners on their views and also people with dementia and the relatives in Germany. You can see the interview topics that we focused on. So in the interviews with the general practitioners, we really focused on the exchange of information with the hospital. So what information do they get? Are these information helpful? Then we asked them about the first consultation. So what do they focus on when the patient is coming with a new diagnosis from the hospital? And we also asked about communication aspects, planning of further care, their own competences and skills regarding dementia, and in general obstacles and facilitating factors. And on the other side, you can see the topics we addressed in the interviews with the people with dementia, which is mainly the same, but on their situation. Regarding the findings, we could conduct 6 interviews with people with dementia and/or relatives. Of course, we wanted to have more of them to see their point of view. But we only had 6 interviews. But we had 16 interviews with primary care physicians, and that's the part I want to focus on in the rest of my presentation. So the average working experiences was 21 years. They were mainly men and in the age between 50 and 59 years old. So the GPs or general practitioners highlighted a lot of challenges taking care of the patients from the hospital. And these were various challenges. So one of the challenges was that there is no holistic view of the patient in hospital. So the general practitioners emphasized that the practitioners in hospital only take care of their area of expertise and don't look at, for example, the family situation, the situation at home. If the patient is getting out of the hospital, do they need acute care? And the patients are being told in the hospital that the general practitioner will take care of everything else. Another thing the interviewed general practitioners pointed out is that there is there is an insufficient differential diagnosis in the hospital. So as the acute reason for hospitalization is not the dementia, there is usually no comprehensive assessment. And it is our general practitioners had the experiences that the diagnosis was being made in the context of an operation or anesthesia. and it is not really checked that precisely in hospital, as you can see in the quote. So they have to make sure it's verified after the hospital stay. So which really depends on the hospital, and it depends on the department. So in the geriatrics and neurological department, they usually don't look at the diagnosis so close, because they do get information about the tests that they were made, but not in other departments. So they get the information from the hospital and just says dementia there. And there they don't really have additional information and have to check and verify the diagnosis. An overall barrier that was mentioned in the interviews was a lack of communication. So a lack of communication as a barrier for adequate care, especially from the hospital side. So the hospital side isn't initiating any communication to ensure that there is a good transition for the patient. So the information, the general practitioners get their information delayed, as you can see in the quote. The letter comes half a year after the patient has died. So they really need the information from the hospital to ensure adequate care. And when the general practitioner tries to call the hospital to clarify any follow-up questions, there's usually no one who can talk with them about the patient, because they don't remember or they were not in charge for that patient. So as there is, on one hand, lack of communication, but also lack of support for the patient, the general practitioners see their role in really encouraging their patient and supporting, especially provide emotional support for their patient. So as you can see, the quote, one physician said, she had to regain a bit of lost ground so that hopelessness does not arise. And that is really what the general practitioners emphasized, that they tried to take away worries and fears and rather put the focus on what they still can do in their day-to-day life. Another thing they tried to emphasize is an open and sensitive communication. They couldn't really tell me how they do this, but they try to carefully explain to the patient what is going on with them. As they don't get the information from the hospital, the patients ask the general practitioner what is going on with me. So they try to take enough time and involve the patient in every step. But they also emphasize an open communication. So they say to the patient not to take it lightly. And as I said, try to involve everyone in the ongoing care. So just to summarize these real quick, the general practitioners do not feel sufficiently involved in inpatient care, and they need to be involved to have all the information and really care for the patient as soon as possible after the diagnosis, and maybe to verify the diagnosis after discharge. There is an insufficient transition from inpatient to outpatient care, which is really affecting the patient as well. And the general practitioners try to encourage their patients. And I asked the general practitioners what do they wish for, what could help them in this phase. So overall they said more communication. We need communication with the hospital. But also they talked about other professional groups that could maybe help, like case managers. We do have projects in Germany with case managers and especially with dementia case managers, but this is not implemented yet. So the general practitioners, they don't have the time to really support their patients and give them all they need. So they want case managers to really connect the social and health professionals to give the patient the support he or she needs. Another thing that was emphasized was social service as a support, the social service in the hospital, but especially this really depends on the hospital as well. But sometimes the general practitioners have the feeling that the social workers were not equipped to taking care of people with dementia, and it is important to support them when they get the diagnosis and not 2 weeks after when they see their general practitioners. And the last thing is an effective discharge management. We do have a discharge management by law since 5 years now, and it's to ensure really, especially this transition. Therefore, we have a discharge management, but according to the general practitioners asked, it is not working. So they don't have the information they need, and they really need all the information they can get. How was the diagnosis made? What kind of dementia is it? And so on. So that was my short presentation, and thank you for your attention. Just real quick, this is to the project side, which is in German, but there's also my contact, so I will answer in English. If you,
Thank you very much. Thank you very much. Mike? Yeah, no, it's going. Thank you very much, Flora-Marie, for your presentation. Are there any questions here in the room? I don't have any here at the app. So maybe I can ask a question.
Yeah.
As far as I know, the financial system in Germany, there are certain kind of amount of time and DRGs, I don't know whether you know that, in other countries too, the diagnosis-related groups. So there is a certain time and intensity of care attributed to certain diagnoses. And older people usually have the problem that they have to leave hospital sooner as they should. And now, especially if a diagnosis of potential diagnosis of dementia comes additionally. So, how in a situation like this, don't you think that there are other severe physical problems to care for with the GPs? So, how can we really ensure that the dementia diagnosis doesn't become kind of a back noise for them?
that is really a problem because they have to take care of the acute reason why they were in hospital first. This is the acute thing that needs to be solved first, and that is really a problem because they have just it depends on the hospital. But when they do have just the word dementia in their discharge letter, they don't know what to do, and they focus on the one thing that is the acute reason for the hospitalization, and afterwards they have to face the dementia and how they could go on with that. But yeah, that's really a problem.
Especially as you might have kind of positive and engaged selection of your GPs in your situation. As we heard in other sessions as well, GPs very often are also reluctant in communicating about the possible dementia diagnosis, and it's for them maybe the easier way to focus on the physical aspects of the patient's condition at the moment.
Yeah, maybe you just first solve what you can solve, and then...
Yeah, for sure. Okay, so maybe somebody had another question now? Here we go. Yeah.
Nis Peter Nissen from the Danish Alzheimer Associations. As far as we know in Denmark, the patients with dementia, they use the acute hospitalized system more often than other patients in share, and they use the planned hospitalization very less than other patients. So it's probably a problem that is very often seen. But my question is, we also know examples here from Germany and from Denmark that you're working with what we call dementia-friendly hospitals. Are you aware of that? And could that be one of the answers in order to help patients with dementia in acute facilities in hospitals?
Yeah, that's a good point. That would be really helpful that the hospital and especially nurses and doctors are really aware of dementia. That would be way more easy for the patient to get support. That would be good. It's good.
Another one here in the front. Sorry, maybe I missed somebody else. Here.
Thank you. We tried to make a dementia-friendly hospital in Istanbul. They gave up. It's such a difficult task to get all the staff working in the hospital be dementia aware. My question is, could it be this lack of communication be related to the privacy issues, data protection, and the stigma related to dementia? Because the medical doctors who diagnose dementia usually do not like to report it so much, especially in some rural areas where the communities are kind of judgmental. Could that be the reason why this news about dementia is not spread so widely, so quickly?
Yeah, I think there's still a stigma going on, but in the hospital maybe not so much. So there it is really a shortage of professionals who work there, that there is a lack of communication. But in rural areas you have the stigma, and you have I had an interview with one practitioner that was really remarkable. He was in a rural area, and all the time he said, you can't do anything, and so I'm not going to do anything because I can't do anything, and that was really, really frustrating.
This is really an interesting topic, and I see also that the role of GP in general hospitals is also a pending issue across various countries. In Greek Alzheimer Association in Thessaloniki, where I work, we implemented an educational project in nurses who work in general hospitals. This project was constituted both of training materials, but also of communication techniques, reflective exercises, emotional exercises, role-playings, and also we implemented the dementia-friendly program which is adapting in Greece, and it seems that their self-esteem as professionals to cope with people living with dementia admitted in general hospitals was really increased, and they were feeling more able to cope with that and to help those people. So I think that starting from nurses, we can also implement such projects in other professionals in general hospitals, because sometimes diagnosis is set in these places due to another reason, another health problem. Thank you.
Yeah, thank you for your comment. That's a really good project.
Over there is another question.
Yes, good morning, René Thüringen from Germany. Thanks for this very nice talk and the good data there. I was just wondering how much of those problems you described are really dementia specific in Germany? Because when thinking about solutions, can we look into other areas? I know, for example, that the cancer area is much better. But can you elaborate a little bit on this, how dementia specific this is when looking for solutions?
Yeah, when we ask for the wishes, do you mean that? So it's a general problem that they don't have a communication with the hospital. That was not dementia specific. I can say that, yeah.
Yes, and the problems, is it really due to the disease dementia that that there is so much, or is it just a lack of communication and a lack of interest between those groups?
They really emphasize is a lack of communication, not regarding the disease, but regarding the information they get about the tests that are being made. And it's easy for the hospital to just write it down. They have it in their computers. Just give it the information to the general practitioner. So it was really a lack of communication, not regarding to the disease. Yeah.
Thank you. Susanna Dooley from Dublin. It would be interesting, wouldn't it, to have a look at how the dementia diagnosis was disclosed to those patients when they were in hospital, and, you know, were advocates brought in, and did they get written information, were family members brought on board? Because, you know, we know ourselves that because of all the multiple variables that affect people communicating their diagnosis of dementia to their other healthcare professionals, family members and people in their community, that if you have a family member on board, that it can actually help with, I suppose, the processing of that information, the acceptance, and that they can advocate then with their general practitioner, regardless of the GP style, to get better care. And just was one other point I was wondering too, you know, that as community-based services increase and improve in terms of social prescribing and community daycare activities, I think sometimes medics feel they have nowhere to refer people on to. So if they spend a lot of time with the patient talking about their diagnosis and dementia, there's nothing they can offer them in terms of an intervention. But in rural areas, as services improve on the ground, and this is what we found in Ireland, that the medics are just so delighted to refer, if they have an intervention they can refer the person onto, then they're much more happy to talk about dementia. Is that something you've come across?
That's really one thing. If they have a good network, like with a specialist and in the community, they do really emphasize and talk about the topic. But if they don't have anything to offer the patient, they avoid the topic. Yeah, we saw that too.
Thank you.
So, okay, thank you very much, Flora-Marie. Thank you very much for your questions. And we come to our next speaker, which was probably supposed to be the second one, but Flora-Marie was so keen on taking over the mic, and I wouldn't stop her, and afterwards I saw, okay, sorry, we just changed, but doesn't matter. So, welcome here on board, Anna Margani. She comes from the Italian-speaking part of Switzerland, and she's a nurse by training and specialized in geriatrics and gerontology. Anna is the director and owner of the VITACORE home care service for people with dementia. She will talk about her project, which aims at the reduction of behavioral and psychological symptoms of dementia. Anna.
Hi, good morning, everybody. Okay, we have been open since 2021, the project of the New Day and Night Therapeutic Center CASA VITACORE. Arise from need on the part of the territory and to give a more adequate response to the family caregiver. Often at home it's not possible to take action on some problem, and it's not possible to respond optimally to needs of the family. But 9 months after the opening, we got an unexpected result. 18.5% reduction of behavior disorder, reduction of neuroleptic therapy, and improving people's lives. We treated 35 persons between 62 and 96 years old. We treated behavioral anxiety, aggression, agitation, sleep disorder, eating disorder. What tools did we use? Neuropsychiatric inventory and test cane. Now you can see from the graph at time 0 and after 9 months how the disorder have changed. Okay. Here can see at time 0 and after 9 months how the use of neuroleptic therapy change. Is very important. And here you can see at time 0 and after 9 months the level of socialization with test cane. The people with dementia have increased this level. What led to a satisfactory result in such a short time? We have identified 2 key factors. Living space, application of psychosocial intervention, and the use of a personality approach with the observation and acceptance of emotion. Okay. Now let's see the first key factor, the living space. We can divide it into two parts, the physical space and aromatherapy. Now we see the pictures of living space. Here we see the living room. You can observe the white space, the color used. Here the relax room. Here the kitchen, much used by people with dementia. The dining room. Okay. Summing up, we can say that the living space represents the everyday life of their home, family atmosphere, some future quiet, welcoming, safety, large space without a blind zone, well-defined space, a well-defined color. With harmony. Aromatherapy is very important. It facilitates the entry into relationship with the person with dementia, and applied and touch massage or diffusion. The second key factor is the approach to the person. We have applied the person-centered care by Tom Kitwood and observation and acceptance of emotion. We have considered the 6 basic psychological needs. Allora, I go where we respect and I love each other. This is a phrase said by a person with dementia and demonstrated how they perceive life in the center. Okay. Now I present to you some pictures from the life of the people with dementia in the center. Okay. You can see how they see the center is their home, their feel at home, how they help each other, and home dresses. Okay. Activity in the kitchen, live at home. They all help to keep the center clean, helping as they can. Gardening. Okay. Help on the farm. Okay. Preparation of the snack. There is always the supervision of the care staff, but it's not a substitute. All these activities allow people with dementia to have a role in the center, to feel useful, increases their self-esteem and the motivation their life. At the end of the day, they are very happy and motivated for everything done. This is some preparation. In conclusion, this experience allowed us to understand how the living space and the approach can positively influence disorder. Thank you very much for your attention.
So thank you very much, Anna, for your presentation. Again, I don't have any questions here on the app. Maybe there's someone in the room? No? Oh, yeah, over there. Colleague from Greece.
Really interesting presentation and very good ideas for home care settings. I have a question about aromatherapy. Given that some people living with dementia have smell problems, smell reduction, do you implement an evaluation test or something like that in order to select those people who don't have problems and can participate in the aromatherapy project?
In francese? Sì.
Sorry, I have to translate not in Italian but in French, so that she better understands.
The aromatherapy, traduciamo, come posso...
So we have a language problem. I don't speak Italian, and my French is kind of so la la. So we kind of do the pantomimic things. No, so
the aromatherapy use also with person of dementia is not.
So it will work even if the smell is not that fine. So.
Parce que why and the massage il not posso dire besoin de.
So if you have the massage, you don't really need to smell everything. So you have at least something you can get from a sensory kind of part. Yeah.
Esatto.
Okay. So I try to ask another question. I ose poser une autre question. Votre first English then French. Your care home or daycare center. It's not only the care center. It also has a huge environment with you mentioned a farm and other possibilities for activities. That's right. Do you understand?
Yes, we are other activity.
So this wasn't quite sure at the beginning. And one last question for me, very important, is people coming to your care home. And you mentioned a lot of very positive effects on people with dementia. What do family members say if they go back? Does it change the behavior or the relationship between them at home? Les effets positifs pour les personnes atteintes, est-ce qu'ils ont un effet aussi?
Allora, nous posso dire, nous sommes come posso dire, la famiglia è presa in charge with nous, con noi.
So the family is
ne présente
in contact?
plus les disturbs à la maison.
Okay. And the behavioral and psychological symptoms, they are also reduced at home, so I guess the family life is much easier then as well. So, okay.
Mi porta il traduttore.
Okay.
Mi porti il traduttore.
Okay. So, anybody else? You can English? Italian, you speak Italian? Oh, sorry, I didn't know that. So now we know about our colleagues here. So
if you want me to translate for you.
Sì.
So, okay, there's one. Okay, we do have also the electronic devices. Which helps a lot. Bridging the gaps.
Okay. Question?
Question, okay. Any other questions? Maybe there's somebody. Yeah. Sorry.
You also mentioned that it should be like a... Oh, sorry.
Perché è così lontano, aspetta.
Okay. I also have a translator next to me.
Okay. Sorry for that. It just came in by the app now. So maybe, how can we do that? So now I'm confused. Yeah. Okay. Maybe you can come, so at least that we get one question and one answer, which is really in the way everybody can profit from that. Would you mind just? Do you have the mic? Because you will have you need the mic for translation because otherwise people online can't hear us. So we start with that. First the question. Okay.
Yeah. Okay.
This helps.
You also mentioned that it should be like a quiet environment. Did you also take into account things regarding the sounds in your environment?
Hai parlato di un ambiente che è molto tranquillo, che deve essere silenzioso, quindi chiedono se tenete anche in conto l'aspetto sonoro nell'ambiente.
Sì, allora, nell'ambiente viene tenuto conto tutto, dal sonoro, dall'evitare quei rumori improvvisi che potrebbero spaventarli. Sì.
So what I try to do is to try to keep the environment as quiet as possible, avoiding some sudden rumors or sounding that can be scaring for the people in the care home.
Perfect. Thank you very much. Okay, so I don't see any other questions, also not here on the app. So thanks again, Diana, and thanks again for helping and really building the bridges between the languages. It was very helpful as well. Thank you. So now we're coming to our last speaker, that's Laura Cole. Laura has a background in psychology and worked with older people living with cognitive problems and dementia for over 20 years in various clinical, care and research settings. She's a senior lecturer and course leader for the Master of Science in Dementia Care and a visiting research fellow at King's College in London. In previous research, she has investigated the best time to move to a care home and use residential respite for people living with dementia. Laura will provide us with insights into experiences of a very common but rarely addressed situation at home, intimate continence care, and she will present findings from her PhD work. Laura, looking forward to that. Thank you.
Thank you very much for that introduction. Hello. I'm Laura, and I'm going to present to you today the experience of intimate continence care and the impact this has on the family-dyad relationship. And by family-dyad, I mean the person with dementia and the family carer. So this research was done with my colleagues, with their names there, Professor Brennan, Professor Jill Manthorpe, Professor Eleni Hatzidemetriadou, and Professor Steve Eilif. And as Stefanie quite rightly said, I'm now based at the Gala Institute for Ageing and Memory at the University of West London in the UK. Clicker. And here is just a quick disclaimer. Our funders were from the NIHR in England. I'll leave that for you to read. So just a quick background on what do I mean by intimate continence care. So this is when someone either provides or receives care with or support with managing excreta. And when I say excreta, I mean urine and feces. So for many people living at home with dementia, this type of care is provided by a family member. And it's known that managing incontinence can be a significant factor in the decision to move to a care home for people living with dementia. However, we don't really know what it is about the incontinence. Is it just the incontinence itself, or is there something underlining that sort of precipitates this decision to move to a care home? So we need to investigate this further, because there really is very little research in this area. So the aim of my study is to investigate the experience of people living with dementia and the main family carer, the family-dyad, when managing intimate continence care at home, but also to investigate whether this intimate continence care affected the family-dyad relationship, so the relationship between the person with dementia and the family carer. And then to consider the implications for health and social care professionals when supporting people with dementia and their family carers. So, how did we do this? So we did a longitudinal qualitative study, taking a phenomenological approach. So, in basic terms, we did a study over time, and we wanted to get the data, get the voices of people with dementia and family carers, and then let that inform our findings. So taking the voice of people to say, what's it like for you? You tell us, and then that will be our findings. So we wanted people who were in dyads, so the focus would be the dyad themselves, so it'd be a family member and a person with dementia, that's the dyad. So several we obviously wanted to interview several dyads over time in semi-structured interviews, which we recorded, transcribed, and then analysed using the phenomenological approach. I had a topic guide for this, and I also took field notes, and also recorded demographic and health information. So just to say that the sample, the dyads, actually came from a larger parent study where we were looking at incontinence at home with people with dementia, family carers. So I invited people from that larger cohort if they would like to take part in the study. They obviously needed to have, the person with dementia needed to have some kind of issues with incontinence. They needed to be, a person with dementia needed to be cared for at home by somebody, so in the same household. And the person, all participants needed to be able to give their capacity, needed to have capacity to be able to consent into the research, because obviously it's important that people know that I'm a researcher, I'm not a practitioner, and that they're obviously informed of what they're being involved in when they're being interviewed in this way. So that's who we were looking for. And then just to say that this is the overtime element. So at point one, interview one, I would interview dyads about their relationship now, their relationship in the past, maybe before the dementia diagnosis, but then also to ask about the incontinence now as well. And then we follow up again in 6 months' time, and there would be an interview 2, and then 6 months' time again, interview 3. And this really helped, because as you can imagine, talking about incontinence is not always easy for everyone. So we thought this would really help with the data, to collect as rich data as possible, and obviously building those relationships over time to get people to trust me to and what we're doing. So that was, again, the plan. So we actually managed to get 13 family dyads into the study. So 13 carers took part, and then very lucky to have one person living with dementia, but clearly that wasn't what we were aiming for. We were aiming for much more, but unfortunately that was due to the capacity issues. Most of the participants identified as their ethnicity as white British, although there was a little bit variation. Most people living with dementia had an Alzheimer's disease diagnosis, as probably to be expected. And most people with dementia within the dyads were in the severe stages of dementia. And again, that supports why, unfortunately, we weren't able to interview more people within the more people with dementia within the dyads. 10 people living with dementia experienced double incontinence. So what I mean by that is that they had incontinence of urine and feces. So it's double incontinence. And the relationship types between and in the dyads was quite varied. So we had 7 spouses, 5 adult children, and 1 sibling. So, our findings, just to say before I go on to the overarching themes, is that actually we thought it would be difficult to talk about these things with family carers, but it wasn't. And the reason why it wasn't is because nobody asked them about these types of issues. So when you do ask about these questions, the floodgates open. And participants even said things like to me, I'm really sorry that we're talking about these kinds of issues. It's not very nice for you to talk about. And I say, but that's what I'm here for. That's what I asked you the question. And they're like, oh yeah, because once talking about it, they had this experience. It was quite cathartic, and they actually reflected on the fact that nobody has asked me this before. Nobody asked me, what do I do in this respect? So actually, it's quite nice to be able to say, actually, I do this, I do that, and wow, I'm doing all this, you know. So actually, it was quite nice, if you like, for people to have that space to be able to talk about these things that they do every day. So the 3 overarching themes that were found was first of all, the managing excreta, providing support with intimate continence care. What did that feel like? So that was the carers mainly. Then participants talked about the support from health and social care services. And then finally, the impact on the dyad relationships. I'm just going to take you through each of those because they have sub-themes, and take you through some of the quotes as well. Okay, so the first one, managing excreta and providing support with intimate continence care. So as you can imagine, the first thing really is that it's not a pleasant task, and participants felt quite sort of negative about what they were doing. You know, some people described it as quite, disgusting and, oh, it's horrible. But other things came up, like, for example, this quote here from the brother who was caring for his sister about some of the thoughts and maybe the sort of this going against social norms. So I asked him, for example, what's it like for you to support your sister with using the toilet? And in this conversation, he said, you seem to be posing a question to me as if, what's this guy doing? He shouldn't be doing this. Now, of course, that wasn't at all what I was doing, but it seemed to me that maybe this was reflecting some of his anxieties about what people might be thinking about him providing this type of care. And we've seen this kind of thing in care workers too, but obviously this is a family situation, so we have additional dynamics there as well. Perceptions of necessity. Many carers particularly just said, well, it's a case of having to. I'm not going to leave the person like, in a situation where they're wet or soiled. So, and the daughter says here, well, it's just a job, as I say, you just get on with it. It would bother me far more to leave it. So many of the carers saw incontinence, intimate continence care is very task-focused. So there was, for example, a soiled pad It needed to get into a bag and into a bin. It was just that. Didn't really think about it. It was just a necessity. It had to be dealt with. And then there was this other side of it as well, this emotional need to provide intimate care. That need of, well, I love this person, of course I'm going to do it for them. And this daughter said, I wouldn't like other people to do it. You know, I sort of like doing it. You know, I like doing the caring. So for her, it was very important that I think this is to do with, you know, upholding someone's dignity, about not having other people coming into the home who may be strangers, and then having that the person caring for the person themselves. And then finally, D, difficult, challenging experiences when using the toilet and managing continence. So these were some of the difficulties that carers were having when possibly the person with dementia didn't know what was happening. So maybe they were using the toilet, and in this instance, the daughter says, if she won't let me take her pants down, they're the things that irritate me, not the fact that she's wet, or you know. So it's not the incontinence itself, it was that kind of interaction of supporting somebody, but obviously if they're not sure what you're doing, then they're not wanting you to help in that way, then there might be some confusion, and then there's some resistance. So for some carers, that was just really hard work and quite distressing. So moving on to the second overarching theme, support from health and social care services in managing continence at home. Generally, in the UK, we obviously have the health system and then the social care system, and there just seemed to be a lack of integration between the two, but also within each of those as well. So, for example, one carer talked about trying to support her mum with continence care, but also her mum had a bed sore from being in hospital, so it was trying to marry up the district nurse, the GP, trying to get the dressings from the pharmacy, and then trying to get the care staff to come in all at the same time, and the district nurse all at the same time, because there was no point having a clean dressing on the wound if the continence hadn't been addressed at the same time. So it all needed to happen at the same time, and it was very difficult for the carer to manage all these things at the same time. But this quote is from a son who was trying to get pull-up pads for his mother. He knew that in other local authorities in London that was a possibility, but it seemed for him in his local authority that it wasn't allowed, and it wasn't something that he could to get. So he says, I had to not only help care for my mum, but I had to, in effect, battle with the authorities to even get that basic need for her. I think it's a bit of a scandal because in some way, indirect way, I'm sure it had an impact, a detrimental impact on my mum. Made me more tired, maybe I was sometimes I could get agitated. And my mum, because I was tired, which is a shame. So basically he's saying that instead of spending time with his mum, if he wasn't doing care activities, he could sit down, maybe have a cup of tea with her, have a chat or whatever. He was off on the phone trying to get the services that he needed and able to support her at home. And that was a common theme from carers, that they felt, using words like fighting for what I need, battling with the care professionals. And then moving down to B as the social care aspect of things. And that's sometimes when people wanted the care to remain at home. They wanted to be in control of the care at home. Even if they had to have care workers come into the home, they still wanted to feel in control. So they didn't want that to be taken away from them. So in this instance, they were saying, the wife said, now they have to go into the bedroom, which obviously is seen as a private space. And then finally, moving to the impact on the dyad relationship. Basically, everyone, including the person with dementia, said that intimate continence care didn't affect the relationship in a negative way, which possibly might be quite surprising. And that generally it was the dementia that was actually affecting the relationship due to communication. Intimate continent care makes the relationship stronger, and maybe that's because obviously you are providing something or you're accepting something between you that actually brings you closer together. You're in it together as a couple. So again, that's maybe something that was quite a finding. However, from my point of view, I can also see that there were some indirect effects that intimate care was having. So in fact, I won't read this quote to you, but you can see here this gentleman has actually moved from a double bed to single bed with his wife. So he was in a single bed and she was in a single bed because it saved on the washing. If there was a wet bed, then he can just take one of the sheets off and it's much quicker. But you can see there how it affects the intimacy in their relationship. Sorry. And then just in conclusion, we can see that the implications from the study is that an integrated and effective continence service providing effective continence support could maximise the quality of life for the family-dyad, delay unwanted moves to a care home, maximise the quality of the dyad relationship, and really this should be a priority for service funders and quality assurance regulators. Thank you for listening.
So thanks a lot, dear Laura, and I'd like to join one of the colleagues here. Somebody said, congratulations, unbelievably interesting research. Thank you very much for that. So I have a first question here, and a comment. As a former family carer, it wasn't so much the incontinence, the practical side that was upsetting, but my person with dementia's reaction to it and associated behaviors. We often don't discuss it because we want to protect the dignity of the person. How do we open this up as a subject for discussion and help carers to be prepared?
Yes, and it is a difficult one because obviously incontinence is not something that people often discuss. It can be difficult to bring up, but I think practitioners definitely, need to be asking the questions, and I don't think they have been. So I think, and if you can be brave and to bring up the questions, but also if you're family carer, to bring the subject up yourself as well and talk about the difficulties you're having. Opening up the dialogue is definitely the best way to go. And it is difficult to help support somebody when they might not understand what you're doing. So I think if you can get any support with that, and that starts with just telling somebody the problem.
Thank you. Any questions here in the room? Yeah, over there. Thank you.
Reiterating the words, reiterating the words of the online participants. Thanks for this presentation. Very interesting. We all know it's important, and we all know we don't talk about it. So that's great that you address that issue, that theme. My first question was answered by your last slide, but that took about 5 seconds on screen. So if that can be put up again, because I want to read up on the subject and on your research. So the details of the publications would be welcome. And the second one refers to the presentation we had yesterday in the plenary by Wiesje van der Fleur about communicating the diagnosis. And she at one moment said, well, we went to the oncology and listened to that field because they, of course, also communicate news about diagnosis. I want to make a parallel question. Did you look into childcare and how they deal with this? Because we all know that babies take a couple of years before they're continent, and that we as parents have to deal with this subject in those first years. Is there any lessons to be learned?
Very good question. So I don't know if the last slide can... Oh, thank you very much. that's the first slide. Do you want me to flick through? And I can get the last slide for you so you can have a look at the publication. In terms of your second question, no, I haven't looked at for children, incontinence for children, mainly because I feel that there is the difference between, obviously we don't want to infantilize older people. Also, that there's a lot of differences with older people in the terms of how much incontinence and also personhood as well. I know we should obviously be looking after children in the same way as in their personhood, but I think there's some very unique challenges for adults with this, and obviously with the dementia as well. But certainly we can look at people with intellectual disabilities, perhaps, and broaden that a bit wider. Thank you.
So I don't see Charles. Yeah, over there. One more question, and I have another comment. A very interesting presentation. Just to give you the feedback as well.
Just a short question. I was wondering whether you would observe the same results in people who have motor impairment, like people with ALS, motor neuron disease, or have suffered a stroke, but are able to communicate. Whether you would notice differences in the way incontinence is managed between the two different cohorts.
Yes, absolutely. We definitely need more research in this area, so I think that would be very interesting to look at and compare to separate but similar cohorts. So I think, yeah, and I invite anybody who's researchers in the room to continue with this type of research. Yeah. Thank you.
Okay, thank you very much. I think we can close the session now because I also have here another kind of challenge, because this clock shows me it's 11:30. My clock says it's 12 o'clock. I think it's 12 o'clock. You're getting kind of hungry now. Okay, so thanks again to all the speakers for the interesting talks. I think it's the aspects highlighted are very important for people with dementia. It's about their dignity and the quality of life, so it's important to have them.